Hello everybody, this is Victoria. I am back again with part 2 of my gynecology study guide for the Women's Health EOR and for the Pance, and if you're studying for your end of curriculum exam too. So I'm going to be starting off today with breast disorders. We're going to be starting with fibrocystic breast changes. These are non-cancerous fluid-filled breast cysts due to an exaggerated response to hormones. This is also known as glandular hyperplasia. It causes duct dilation, breast cysts, and stromal fibrosis. This is the most common benign breast disorder in reproductive age women. It often stops after menopause. The clinical manifestations. So it may cause asymptomatic breast lumps that are only discovered on palpation, but more likely it causes multiple painful or painless, mobile, ill-defined breast masses that may increase or decrease in size with menstrual hormonal changes. This often occurs or becomes worse prior to menstruation. The fluctuations in size and the rapid appearance or disappearance is very characteristic of this disorder. And it's often what will distinguish it from the other disorders. There may be non-bloody green or brown discharge from the nipple, pain, fluctuation in size, and multiplicity of lesions is useful, like I was saying. Physical examination will usually reveal multiple nodular, mobile, smooth, round, or ovoid lumps in both breasts of varying sizes. They're often bilateral but not associated with axillary lymph node involvement. This is most commonly found in the upper outer sections of the breast. The initial imaging of choice is ultrasound. Fine needle aspiration is not usually performed, but when it is, it'll often pull straw-colored or green fluid. A mammogram may be required if the lesion is suspicious or if it's persistent after drainage. Management, supportive management, really it's observation, reassurance, supportive bra, warm or cool compresses, analgesia with acetaminophen or NSAIDs, and that's if they're painful. Oral contraceptives can sometimes reduce symptoms, and the fine needle aspiration removal fluid is diagnostic and therapeutic in complex cases or especially painful cases. So now we'll talk about fibroadenomas. These are benign, solid tumors composed of glandular and fibrous tissue. They are hormone dependent. This is the second most common benign breast mass after fibrocystic disease, and it's the most common breast tumor in women younger than 30. On exam, it will be a round, firm, discrete, relatively mobile mass between 1 and 5 centimeters. It's usually non-tender, but can become tender prior to menstruation. It'll grow over time, but may enlarge in pregnancy. Does not change significantly in size with the menstrual cycle, which is what will distinguish it from fibrocystic disease. Physical examination. There will be firm, non-tender, solitary, smooth, well-circumscribed, freely mobile, rubbery lumps in the breast, usually 2 to 3 centimeters, with no axillary involvement, similar to fibrocystic disease that way. This is a clinical diagnosis. Ultrasound would show a solid, well-circumscribed avascular mass with benign features. Fine needle aspiration is a definitive diagnosis. This shows fibrous tissue and collagen arranged in a swirl. Management is often conservative. It's observation, reassurance, and follow-up. Most small tumors reabsorb with time. You can repeat the ultrasound in 3 to 6 months or do a core biopsy in complex cases or when the patient is older. Local excision is sometimes indicated if the mass is enlarging after repeat ultrasounds or if it's especially large. Next, we'll talk about mastitis. The first type is congestive mastitis. This is bilateral breast enlargement 2 to 3 days postpartum due to milk stasis. Bilateral breast pain and swelling are the two main symptoms here. Management: breast drainage is the mainstay of treatment. So either manually, via breast pump, or hand expression. If the woman does not want to breastfeed, treat with ice packs, tight-fitting bras, analgesia, and breast drainage. If breastfeeding is desired, manually empty the breast completely after the baby is done breastfeeding. Add local heat, analgesia, and continue nursing. Then there's infective lactational mastitis. So this is an infection of the breast, most common in lactating women, secondary to nipple trauma in the first 12 weeks postpartum, especially preemie gravida or women who are having their first baby in the first 6 weeks postpartum. Staphylococcus aureus is the most common, including MRSA, and this makes sense considering Staph aureus colonizes the skin. Any inflammatory breast in a postmenopausal woman is cancer until proven otherwise, so don't think mastitis in these cases. Manifestations include unilateral, localized breast pain, tenderness, warmth, swelling, induration, and skin redness. Systemic symptoms may include fever, chills, or myalgias, and it's common in the first 3 months postpartum, like I was saying. Exam will show firm, red, tender, and swollen areas of one breast associated with a fever. Sore, cracked nipples, or visible fissures may be possible there, and sometimes there's purulent nipple discharge. Most of the time, this is a clinical diagnosis. It's a woman presenting as a nursing mother with breast pain, redness, and swelling. Culture of breast milk is sometimes used in order to guide antibiotic therapy. Imaging is not usually used, but if the mastitis is not responding to the antibiotics within 48 to 72 hours, then you can consider it then. So, management: the first being supportive with pain control, warm or cool compresses and NSAIDs. Emptying of the breasts is a main form of treatment here. It's critical for the resolution of the infection and for relief of symptoms. Antibiotic therapy with activity against S. aureus is added if the symptoms are persistent past 12 to 24 hours. If you start only with supportive, and then if that's not helping in 12 to 24 hours, then you add the antibiotics. So anti-staphylococcal antibiotics include dicloxacillin and nafcillin. You can use a cephalosporin. Erythromycin is used if the patient is penicillin allergic. If this does happen to be a fungal infection, then use fluconazole, but you're unlikely to see this on an exam. Breast abscesses. So this is a rare complication of acute mastitis. It's most common in lactating women secondary to nipple trauma. It's exactly the same as infective mastitis. Staph aureus is again the most common. The symptoms are the same as acute mastitis in that there's unilateral breast pain, especially in one quadrant, with tenderness, warmth, and swelling. The nipples may be cracked or there may be a visible fissure, but this time there's also induration and fluctuance, which is a key characteristic of abscesses, no matter where they are. And there may be purulent nipple discharge. This is a clinical diagnosis based on the exam. Breast ultrasound is sometimes ordered if there is a question of whether this is a case of cellulitis or an abscess. An ill-defined mass with septations is what suggests a breast abscess. So the images I have on this slide, there is one there of a breast abscess, and then next to that are fibrocystic changes. You could see the very distinct and just like nothing in them cysts for fibrocystic changes. And then the fibroadenoma is just like solid, not vascular, no calcifications, like it's just a solid blob. But management of a breast abscess, drainage via needle aspiration or incision and drainage plus antibiotics are key. Antibiotics include dicloxacillin and cephalexin. If MRSA, then use clindamycin or Bactrim unless the infant is less than 1 month old. So I really only keep Bactrim in mind as something not to answer. Breast infection, including breast abscesses, is not a contraindication to breastfeeding. I have never understood this, but like I don't understand why you would let the baby keep drinking it if it's infected, but that's what my textbooks say, what Pance Prep Pro says, what everything says is it's not a contraindication. So take that as you will. So this is a mammogram. Basically, I'm unsure if there is like mammogram reading on the EOR, so I figured I would include this anyway. And it is how to distinguish like normal versus cysts versus calcifications. I thought this was a very good image. The benign cyst is kind of like what the fibroadenoma looked like. Like it's a very distinct with no like changes inside, whereas the breast cancer obviously looks, it's like flaring up because of the vascularity and everything. It's not very regular. So yeah, I thought that might be helpful. I'm unsure if there's mammograms on the EOR. Okay, next are structural disorders. Cystoceles will go first. This is a prolapse of the posterior bladder wall into the anterior vagina. Etiologies include childbirth, constipation, heavy lifting, or other pelvic muscle strain. Symptoms include pelvic or vaginal pressure, discomfort with straining, feeling of incomplete voiding, or a sensation of sitting on a ball or something's going to fall out. It's worse with the Valsalva maneuver, and sometimes you may see concurrent urinary incontinence. Diagnosis is made with speculum and bimanual examinations. It may be helpful to only use a single blade of the speculum. So if you like take the top part off, and that way you could visualize the anterior and posterior vaginal walls without the speculum being in the way. If there is no prolapse with the patient laying down, but you have a strong suspicion, also examine them while standing. POP-Q is the pelvic organ prolapse quantification staging system, and it's based on the location of the prolapse in relation to the hymen. So there is stage 0 up to stage 4. It's useful for tracking progression of the prolapse over time and the response to treatment. An alternative is the Baden-Walker grading system, but I don't think we'll need to know all of those anyway, so I figured I wouldn't go into it. Other testing includes ultrasound, voiding cystourethrogram, MRI, or cystometrogram. Management, conservative is the first line. This includes a flexible ring pessary to support the bladder, pelvic floor exercises to strengthen the levator ani and perineal muscles. Surgical repair with mesh augmentation is best for symptomatic women who desire the surgery. It is elective unless the prolapse is causing urinary retention, in which case it may become necessary. Prophylaxis against pelvic floor prolapses, pelvic floor exercises will strengthen the muscles, and that could help prevent prolapse. Estrogen therapy after menopause can maintain the tone of the pelvic tissues and reduce the risk of prolapse. Topical estrogen may also be given with pessaries in order to reduce the risk of vaginal wall erosions. Next, we'll talk about rectoceles. This is herniation of the anterior rectum into the posterior wall of the vagina. Etiologies, the main one here is childbirth, and the other risks are similar to cystoceles in that anything causing a pelvic muscle strain, will increase the risk of erectocele. Symptoms include pelvic pressure and bowel symptoms, a soft bulge of tissue in the vagina that may or may not protrude through the vaginal opening, defecatory dysfunction, meaning constipation, straining, incomplete emptying. Something that an exam question might say that I've seen before is that a woman needs to put her fingers in her vagina and press against the walls in order to be able to go to the bathroom. Another symptom is low back pain. Diagnosis, again, with the POPQ system. You could also get a colonoscopy to rule out cancer and rectal studies if indicated. Treatment, start with conservative, just like cystoceles. Treat constipation, place a pessary, and pelvic floor muscle exercises may help. Surgical management with traditional posterior colpography or site-specific defect repair for women who desire surgical management. Next, we'll talk about uterine prolapses, which is uterine herniation into the vagina. It's caused by weakness of the pelvic support structures, again, most common after childbirth. Manifestations include vaginal fullness, heaviness, or a falling out sensation, low back pain and abdominal pain, and symptoms may be worse with prolonged standing and relieved with lying down. May also be associated with urinary urgency, frequency, or incontinence. Physical examination will show a bulging mass, especially with increased intra-abdominal pressure, meaning the Valsalva maneuver. They are grades 0 to 4, again, the POPQ system used to diagnose, and it may also be accompanied by a cystocele or an enterocele, which is through the pouch of Douglas, the small bowel herniating into the upper vagina, or erectocele, really. The uterine prolapses can be accompanied by any of the other pelvic organ prolapses. And I included a photo here of all of them, the ones I just mentioned here, that you can see where the structures are coming from and might make it easier to visualize. Again, is it surprising that conservative management is the first line? Behavioral modifications and weight control are also. Pessaries elevate and support the uterus, and estrogen treatment may improve atrophy, especially for reducing the irritation from a pessary. Surgical management is with hysterectomy, or a uterus sparing technique may include a uterosacral or sacrospinatus ligament fixation. Okay, now last for structural disorders, ovarian torsion. So, ovarian torsion is the complete or partial rotation of the ovary on its ligamental supports, which results in ischemia that can compromise ovarian blood flow. Prolonged ischemia may lead to infarction. The risk factor is an ovarian mass. It's usually a mechanical complication in patients with functional ovarian cysts or ovarian neoplasms, and that will lead to torsion on occasion. It can also occur without a mass, but this is also more common in children. Clinical manifestations include acute pelvic or abdominal pain that is abrupt in onset and is unilateral in the lower quadrants of abdominal pain. It's sharp, focal, and is often accompanied by nausea and vomiting. A history of recent exercise or a sudden increase in abdominal pressure may hint at an inciting event. Physical examination will show abdominal tenderness or an adnexal mass. The initial test of choice is an ultrasound with Doppler, which will show decreased ovarian blood flow. Normal flow does not exclude torsion, so a definitive diagnosis is made during surgical exploration. You could also use an MRI. Transvaginal ultrasound can be initial imaging too, but the diagnosis, again, has to be done with direct visualization. Management: laparoscopy with detorsion to restore blood flow, An ovarian cystectomy may be needed to remove the responsible cyst and to preserve the ovary in premenopausal women. Salpingo-oophorectomy if the ovary is necrotic, if the cyst, if present, is suspicious for malignancy, or if a woman is postmenopausal and it won't really matter to remove it. All right, so now we can move on to other conditions, which is a very, very broad category. So, endometriosis first. So, implantation of the endometrial tissue, stroma, and gland tissue outside of the uterus, so it's considered ectopic. Most common gynecological cause of secondary dysmenorrhea. It affects up to 10% of women of reproductive age, and the peak incidence is between 25 and 35. The ectopic endometrial tissue responds to the cyclical hormonal changes. It's an estrogen-stimulated inflammatory response. Therefore, symptoms usually improve during pregnancy and after menopause. Locations: ovaries are the most common site, but it could also be found in the posterior broad ligaments, posterior cul-de-sac, anterior cul-de-sac, and the uterosacral ligaments. It's uncommon but possible to see it in the rectosigmoid colon or bladder. Risk factors include prolonged estrogen exposure, which might be nulliparity, a late first pregnancy, early menarche, and short menstrual cycles. Other risks include family history. Reduced risk is with regular exercise, higher parity, late menarche, and longer duration of lactation. The classic triad for endometriosis is cyclic premenstrual pelvic pain, 1 to 2 weeks before menstruation, dysmenorrhea, which is painful menstruation, and dyspareunia, which is painful intercourse. Pelvic pain or pressure that is both related to menses and occurs at times other than menses. That is a very key point with endometriosis, is that the pain is related to menses, but not isolated to menses. The patient may also have dyschezia, which is painful defecation. They might have abnormal bleeding, which could include spotting, or it might just be heavy menstrual bleeding. You might see back or abdominal pain. About 1/3 of patients are asymptomatic. Endometriosis ultimately may cause infertility in about 30 to 47% of infertile women. This is the cause. Physical exam is usually normal, but you might find a fixed tender adnexal mass, a fixed retroverted uterus, or nodular masses along thickened uterosacral ligaments, posterior uterus, or the cul-de-sac. Diagnosis is largely clinical, but we'll move here. So, a pelvic ultrasound is the initial imaging of choice to rule out other causes. Laparoscopy with biopsy is a definitive diagnosis because it allows for histological examination. On histology, you'll see raised patches of thickened, discolored, scarred, or powder burn appearing implants of tissue. And then what I have a photo of here is an ultrasound image of an endometrioma, which often involves the ovaries. And it's large enough to be considered a tumor. It's usually filled with old blood, which is why it's called a chocolate cyst. Expectant management if asymptomatic, or if mild symptoms. NSAIDs can be given for pain. Ovulation suppression with oral contraceptive pills can also be given. Surgical management with conservative laparoscopy and ablation of ectopic endometrial tissue is used if the patient desires fertility. This preserves the uterus and the ovaries and improves pregnancy rates. Large endometriomas are often resected. Total abdominal hysterectomy and bilateral salpingo-oophorectomy is the definitive management if the patient does not have any desire for fertility, and also if they are premenopausal and don't mind going into menopause. Now, we'll go and talk about adenomyosis, which is islands of ectopic endometrial tissue within the myometrium, which is the muscular layer of the uterine wall. This is most commonly presenting in the later reproductive years, between ages 35 to 50 most commonly. Manifestations: most patients are asymptomatic, but this condition may cause infertility. Main clinical features include chronic pelvic pain and dysmenorrhea. Abnormal uterine bleeding is extremely key here. Menorrhagia, or heavy/prolonged uterine bleeding that progressively worsens, is a characteristic finding. Physical exam may show a symmetrically diffusely enlarged, globular, soft, boggy, mobile uterus. It may also be tender. Diagnosis: it's a clinical diagnosis of exclusion in the workup of secondary amenorrhea, but transvaginal ultrasound can also be used and would show a diffusely enlarged uterus, asymptomatic thickening of the myometrium, poorly visualized endometrial myometrial junction, and absent vascular flow to the myometrial lesions, and sometimes cystic lesions in the myometrium. MRI is more accurate and useful when the transvaginal ultrasound fails to elucidate a diagnosis. This would provide clearer visualization of the transition between the endometrium and the myometrium. Post-total abdominal hysterectomy examination of the uterus is a definitive diagnosis. Conservative management is used to preserve fertility. Medications include analgesics, progestins, such as a levonorgestrel-releasing intrauterine device. This is the preferred hormonal treatment over oral contraceptives, but you may also use aromatase inhibitors or GnRH agonists. The only real effective therapy is a total abdominal hysterectomy. Sometimes you could try uterine artery embolization. Next, we will be talking about leiomyomas. So, these are also known as uterine fibroids and can also be called fibromyomas or myomas. Benign uterine smooth muscle tumors that derive from the muscle cells of the myometrium is the most common benign gynecologic tumor. The types are intramural, submucosal, subserosal, and parasitic. Those are dependent on the location. Growth is estrogen dependent, meaning it may increase in size with relation to the menstrual cycle or states without ovulation, such as during pregnancy. Risk factors include increasing age, especially over 35, and this is very important. This is 5 times more common in African American women. Clinical manifestations: most are asymptomatic and found incidentally. Abnormal uterine bleeding is the most common symptom, so it could be heavy, prolonged, or irregular bleeding. Pelvic pain and pressure, including low back pain, pelvic pain, menstrual pain, are all common. These may be interpreted as menstrual cramps or just dysmenorrhea. Reproductive dysfunction is another symptom that patients may observe if they are trying to conceive. Physical exam is normal, or there may be a palpable, discrete, firm, non-tender, and asymmetric or irregular contour mobile mass or masses in the abdomen or pelvis on bimanual exam. So this is different from adenomyosis because adenomyosis was symmetric. It was like boggy, so not exactly firm, and it could be tender or non-tender, and it was moderately mobile, whereas leiomyomas are discrete, firm, non-tender, asymmetric, and they're mobile on the uterus. Diagnosis: the most widely used is transvaginal ultrasound. This is usually used initially. It'll show a focal heterogenic hypoechoic mass or masses with shadowing. Labs may reveal iron deficiency anemia if associated with heavy bleeding. I actually included an MRI of a leiomyoma. So here you could kind of see that the uterus looks enlarged, first of all. Look at the spine first in order to orient yourself to this image. So the smaller arrow that is just like the head of the arrow without the line, that is showing I think it was an intramural or subserosal leiomyoma. The key point here is that it's not like extending beyond the border of the uterus that you could see like well circumscribed in the image. And then if you look just parallel to the arrow with a line in it, so that is the vaginal canal, if you see it like just below the arrow. And then that leads up to, you could see like a large mass that is pointing to. That's actually the cervix, and it has a cervical fibroid on it. So you can kind of see how the cervix connects to the vaginal canal in this image. Okay, so management, observation, because the majority don't need treatment, especially if they are small or asymptomatic fibroids. Decision to treat is based on symptoms and desire for fertility. Non-surgical options include estrogen, progestin, oral contraceptives. NSAIDs are used for dysmenorrhea. Tranexamic acid and NSAIDs may decrease menstrual blood loss. GnRH analogs like leuprolide or nafarelin are the most effective medical treatment, but are usually only used if near menopause or if the fibroids need to be shrunken 3 to 4 months prior to the hysterectomy or myomectomy. Surgical management. So surgical treatment of choice is a myomectomy, and this is the treatment of choice when women want to preserve their fertility. Other options include uterine artery embolization or endometrial ablation. Hysterectomy is the most definitive treatment. Fibroids are the most common cause, actually, for a hysterectomy. So, key points here. So, when you're taking your exam, asymptomatic women, observation. Symptomatic women who desire fertility go for non-surgical treatment, or if refractory to that, a myomectomy. For symptomatic women desiring definitive management and they do not care about fertility, then go for a hysterectomy. Now we'll move on to ovarian cysts. Ovarian cysts are fluid-filled sacs within the ovaries that are commonly related to ovulation. They're usually unilateral and common in the reproductive years. Most of them spontaneously resolve on their own within a few weeks. Physiologic types include follicular cysts, which are the most common. They occur when follicles fail to rupture and then continue to grow. Corpus luteal cysts are made after a failure to degenerate after ovulation. The theca-lutein cysts are excess beta-HCG causes hyperplasia of the theca internal cells. This is very rare, and is only with pregnancy. Clinical manifestations, most are asymptomatic, but they could cause pelvic pain or pressure, abnormal uterine bleeding, or painful intercourse. Physical exam might show unilateral pelvic pain or tenderness, and a mobile, palpable, cystic adnexal mass. Diagnosis is with transvaginal ultrasound. Follicular cysts will be smooth with thin walls and unilocular. Corpus luteal will be complex, thicker walled with peripheral vascularity. Cysts with a low risk for malignancy will be anechoic, unilocular, and fluid-filled. High risk for malignancy cysts are solid, nodular, with thick septations, and that's when you should consider additional diagnostic methods. Also, make sure you order a beta HCG to rule out pregnancy, and for tumors suspicious of malignancy, order tumor markers like CA125, alpha fetoprotein, and beta HCG. Management, if they are under 8 centimeters, is supportive and expectant management. Most cysts below 8 centimeters are functional and usually resolve spontaneously within 60 days without any treatment. Rest, NSAIDs, and repeat ultrasounds after 1 or 2 menstrual cycles is the best management. Oral contraceptives may prevent recurrence, but they don't treat the existent cysts. Management of cysts over 8 centimeters or persistent cysts, they could do laparoscopy or laparotomy. Management for postmenopausal women include laparoscopy or laparotomy if they are large or if there's an elevated tumor marker CA125. Cysts in postmenopausal women are considered to be malignant until proven otherwise. Now moving on to ruptured physiologic ovarian cysts. Acute pelvic or abdominal pain. So this is an abrupt onset of unilateral lower quadrant abdominal pain, often sharp and focal, and occurring during sexual activity or strenuous physical activity. This could also lead to a tubo-ovarian abscess, which, as we discussed before in the last video, will lead to fever, chills, acute lower abdominal pain, vaginal discharge, and adnexal mass. The initial diagnosis is a pelvic ultrasound, which would show pelvic fluid or an adnexal mass. Most cases of a ruptured cyst are uncomplicated, meaning expectant management is the best choice here, which includes observation, analgesia, and rest. For patients who are hemodynamically unstable or if there's ongoing hemorrhage, then laparoscopy is usually preferred, and they may do a cystectomy, which has preservation of the tissue preferred over a oophorectomy if they are premenopausal. Next, let's talk about PCOS, which is also known as Stein-Leventhal syndrome. This is characterized by bilateral enlarged cystic ovaries, insulin resistance, hyperandrogenism, and amenorrhea or oligomenorrhea. This condition may cause infertility. Untreated PCOS is associated with risk for metabolic syndrome, diabetes, cardiovascular disease, dyslipidemia, endometrial hyperplasia, and endometrial cancer. The pathophysiology. So, ovarian hormonal dysregulation alters the GnRH release, which leads to a relative increase in LH versus FSH production and secretion. This increased LH stimulates excess ovarian androgen production, and the relative decrease of FSH prevents adequate stimulation of aromatase activity within the granulosa cells, which causes decreased androgen conversion to potent estrogen estradiol, which leads to follicular degeneration and immature follicles. Functional ovarian hyperandrogenism causes insulin-resistant hyperinsulinism, which acts on theca cells, increasing steroidogenesis, androgen production, and may lead to obesity. Many patients are asymptomatic, but they seek care due to infertility. Menstrual dysfunction is one of the main characteristics. Oligomenorrhea or secondary amenorrhea, chronic anovulation may result in abnormal uterine bleeding. Increased androgens may lead to hirsutism, which is coarse hair on the face, neck, and abdomen, may also lead to acne and male pattern baldness. Insulin resistance is type 2 diabetes mellitus, and obesity, or may even lead to hypertension. Physical exam may show bilateral enlarged, smooth, mobile ovaries on bimanual exam. The patient may also have acanthosis nigricans, which arises from insulin resistance. It's a darkish, velvety discoloration of the skin, usually in skin folds, such as behind the neck. Diagnosis. So the Rotterdam criteria, you need 2 of the 3 in order to diagnose. The first is hyperandrogenism, as demonstrated by lab findings or clinical signs. Ovulatory dysfunction, as indicated by amenorrhea or oligomenorrhea, and cystic ovaries on ultrasound. Labs include elevated testosterone, elevated LH to FSH ratio over 3:1, and a lipid panel and glucose tolerance test for diabetes and dyslipidemia. Pelvic ultrasound will show bilateral enlarged ovaries and multiple ovarian cysts with a string of pearls appearance, which I have right in the middle there. You can see that image. GnRH agonist stimulation tests demonstrate a rise in serum hydroxyprogesterone. Management. First, lifestyle changes include diet, exercise, and weight loss. This can decrease insulin resistance and regulate the menstrual cycle. Combination oral contraceptives are the mainstay of treatment for menstrual cycle irregularity, hirsutism, and acne. And this is best for patients not trying to actively get pregnant. Anti-androgenic agents, namely spironolactone, will block testosterone receptors, and it can be added if the symptoms persist after the addition of oral contraceptives. Leuprolide and finasteride are other anti-androgenics, but I've actually never seen these used. Infertility. So the treatment of infertility, ovulation induction, so that includes letrozole or clomiphene. Letrozole encourages the ovaries to ovulate by blocking estrogen, which then leads to a higher FSH release, whereas it is associated with a higher ovulation and effective live birth rates than clomiphene or metformin in PCOS. Clomiphene is a selective estrogen receptor modulator, or SERM, that reestablishes ovulation. Metformin is an adjuvant treatment in patients with an abnormal LH to FSH ratio because it may improve menstrual frequency. After pregnancy is confirmed, then it can be discontinued. Wedge resection may help to restore ovulation if clomiphene or letrozole is ineffective. All right. Now, last in the miscellaneous conditions section is urinary incontinence. So we'll start with urge incontinence. Involuntary urine leakage preceded by or accompanied by a sudden urge to urinate due to uninhibited bladder contractions. It's most common in older women, and it's overall due to detrusor muscle overactivity. Clinical manifestations include increased urgency, frequency, small volume, voids, and nocturia. The patient has a strong urge to void and an inability to make it to the restroom on time. Conservative treatment includes bladder training, which is the cornerstone of treatment, lifestyle modifications and Kegel exercises to strengthen the pelvic floor can also decrease frequency of incontinence. Lifestyle therapy and behavioral changes are also useful. Beta-3 adrenergic agonists and antimuscarinic agents are the main medical options. So beta-3 agonists include mirabegron and vibegron, which cause bladder relaxation. They have less adverse effect compared to antimuscarinics, which, speaking of, antimuscarinic drugs include trospium or darafenicin. There's also tolterodine, which can be long or short acting, fesoterodine, oxybutynin, sulfenicin, and propivarine. They block the muscarinic receptor stimulation by acetylcholine and reduce smooth muscle contraction of the bladder. Third-line therapies include botulinum toxic A, which is an office-based injection of Botox into the detrusor muscle. Surgical management includes bladder augmentation, which increases bladder compliance. You can also do sling procedures or urethroplexy. Overflow incontinence is urinary retention and incomplete bladder emptying that leads to involuntary urine leakage once the bladder is full. Hence the name, it overflows. Pathophysiology. The incontinence is caused by either bladder detrusor muscle underactivity or bladder outlet obstruction. The detrusor muscle underactivity, or is also known as bladder atony. This is most common in neurological disorders or autonomic dysfunction. So you can actually see this in patients with peripheral neuropathy. So think diabetes mellitus, vitamin B12 deficiency, or alcoholism. Damage to the spinal detrusor efferent nerves may also cause this, and disorders like multiple sclerosis, spinal injuries, or spinal stenosis. Low estrogen states can also lead to this. So, menopause. Bladder outlet obstruction. This in men is usually due to benign prostatic hypertrophy, but in women, it can be caused by uterine fibroids, pelvic organ prolapse, or a overcorrection of the urethra from a prior pelvic floor surgery. Clinical manifestations include loss of urine without any warning or triggers. It may be continuous. It's leakage or dribbling in the setting of incomplete bladder emptying, weak or intermittent urinary stream and hesitancy. Diagnosis is clinical, and post-void residual urine is over 200 milliliters. The management of bladder atony, intermittent or indwelling catheterization is the first-line treatment. Cholinergics such as bethanechol can increase detrusor muscle activity. We won't go into the management of BPH now because this is women's health. Stress incontinence is involuntary leakage of urine that occurs once the increased abdominal pressure from exertion, coughing, laughing, or sneezing exceeds the pressure in the urethra, and then that will exceed the resistance to urine flow in their urethra, and that causes stress incontinence. It's the most common kind of incontinence in younger women. The etiologies include laxity of the pelvic floor muscles, aka childbirth. Urethral hypermobility is also another cause. Clinical manifestations, urine leakage during times of increased intra-abdominal pressure, coughing, laughing, sneezing, lifting, etc. Management includes pelvic floor exercises. It's the initial treatment of choice for mild to moderate stress incontinence. Lifestyle modifications are often used in conjunction with pelvic floor exercises. Surgery includes a mid-urethral sling, which has a higher success rate than conservative therapy. And finally, we are moving on to neoplastic disorders. Okay, so here we go, starting with breast cancer. This is the most common non-skin malignancy in women. Overall, there is a 1 in 8 lifetime incidence of breast cancer in women. It's the second most commonly diagnosed cancer worldwide and cause of cancer death in women after lung cancer. So risk factors include increasing age. Over 50% of cases occur over age 60, and under 2% of cases occur in patients under 30 years of age. An increased number of menstrual cycles is also a risk factor. So this would be people with nulliparity, meaning they have not had any children, someone with a late first full-term pregnancy, meaning over the age of 35, someone with an early age of menarche, meaning below 12 years old, someone with late menopause, or someone who has never breastfed. Increased estrogen exposure is also a risk factor. So postmenopausal women on hormonal replacement, prolonged unopposed estrogen, obesity, alcohol use. Endometrial cancer also increases the breast cancer risk, and vice versa. Genetic factors. So the BRCA or BRCA1 and BRCA2 or gene mutations are associated with a 60 to 85% lifetime development of breast cancer and a 15 to 40% chance of developing ovarian cancer. BRCA1 is on chromosome 17 and BRCA2 is on chromosome 13. Obesity, type 2 diabetes, and metabolic syndrome are also associated with an increased risk. So now for the types of breast cancer. The most common type, making up 75% of the cases of breast cancer, is infiltrative ductal carcinoma. It's characterized by cords and nests of cells with differing amounts of gland formations, and it's associated with lymphatic metastasis, especially to the axillary nodes. Infiltrative lobular carcinoma makes up 8 to 10% of invasive breast cancers. It's characterized by small cells that insidiously infiltrate the mammary stroma and adipose tissue individually and in a single file pattern. Ductal carcinoma in situ does not penetrate the basement membrane. That's the in situ part. It means it's premalignant. Medullary, muconoid, tubular, papillary, metastatic, and inflammatory are all types of breast cancers. Paget disease of the breast is a ductal carcinoma presenting as an eczematous nipple lesion. This is very uncommon, but it may have bloody discharge from the nipple and it spreads lymphatically. We'll get more into the clinical manifestations later. Pre-malignant lesions, again, there's lobular carcinoma in situ. This is a pre-malignant condition associated with an increased risk of invasive breast cancer in either breast. There's also atypical ductal hyperplasia. Clinical manifestations, so classically, there's going to be a breast or axillary mass that's usually painless, hard, fixed, and immobile with irregular borders. This is the most common presentation. Early on, it might be mobile, and in less than 10% of cases, it might be painful. They might also have unilateral bloody nipple discharge. Physical examination, the mass is most common in the upper outer quadrant. This is in 65% of cases. Skin changes include asymmetric erythema, discoloration, ulceration, skin retraction. This will have dimpling if there's Cooper's ligament involvement. There may also be changes in breast size and contour, nipple inversion, and skin thickening. For locally advanced disease, you might see axillary lymphadenopathy. Metastatic disease, the most common locations are the bone, which most commonly involves the vertebrae, ribs, pelvis, and femur. The lungs, so symptoms might include a dyspnea or cough. The liver might present with abdominal pain, nausea, and jaundice, or the brain. You could think 2 B's, 2 L's. Bone, lungs, liver, brain. Paget disease of the breast presents with a chronic, eczematous, itchy, scaly rash on the nipples and areola that may or may not ooze. A lump is often present. Inflammatory breast cancer is a rapidly progressing, tender, firm, and enlarged breast with skin findings such as erythema, warmth, itching, thickening, or dimpling of the overlying skin. And this is called peau d'orange, is where the skin looks like the peel of an orange due to the lymphatic obstruction. This is associated with a very poor prognosis, and it's usually not associated with a lump. The diagnosis of a breast mass involves a combination of the physical exam, mammography, and fine needle aspiration or a core biopsy. Ultrasound is sometimes used to see if the mass is cystic. This would be more common in younger patients where fibrocystic disease or fibroadenoma might be higher on your differential. Mammography is the initial modality to evaluate breast masses in women over 40 years old. Grouped microcalcifications and spiculated high-density masses are the most specific features and are highly suspicious for malignancy. These are words on an exam that should make you think breast cancer. Mammograms are most effective in older women as early as 40 years old because the breasts are less dense. Ultrasound is recommended as the initial modality to evaluate breast masses in women under 40 due to the high density of the breast tissue. It could also be used to guide a fine needle aspiration with biopsy or determine if a mass seen on mammogram is cystic or solid. Sonographic features suggestive of malignancy include hypoechogenicity, internal calcifications, shadowing, a lesion taller than it is wise, and a spiculated, indistinct, or angular margins. MRI may be used to screen women at high risk for breast cancer, such as people with the BRCA gene mutations. MRI features suggestive of malignancy include a rapid uptake of contrast, irregular or spiculated mass margins, heterogeneous internal enhancement, and enhancing internal septa. Biopsy options. Fine needle aspiration. So really here you need to look at the advantages and disadvantages of different biopsy options, and what the patient wants is a key factor here. So fine needle aspiration, it removes the least amount of tissue, which is helpful for patients concerned with cosmetic appearances, but disadvantages if positive, it doesn't allow for receptor testing, which we'll get into the estrogen, progesterone, or HER2 receptors, and it's associated with a false negative rate of 10%. A large needle or core biopsy allows for receptor testing if it is positive, but it could leave a greater deformity with the procedure, and the needle may miss the lesion. An open biopsy is the most accurate diagnostic test, and it allows for a frozen section to be done following the immediate resection of cancer and sentinel node biopsy, but it removes the most tissue. Breast cancer management. Treatment is based on TNM staging. Metastatic workup is recommended for stage 3 and above. Early stage cancer. So management includes breast conservation therapy, meaning lumpectomy, with a sentinel node biopsy and follow-up adjuvant radiation. This is preferred, when possible, to maximize local regional control. A negative sentinel node eliminates the need for axillary lymph node dissection. Locally advanced patient or cancer, most patients are treated with neoadjuvant systemic therapy rather than proceeding with primary surgery. Radiation therapy is usually done after lumpectomy or post-mastectomy as adjuvant therapy to destroy residual tumor cells. Anti-estrogen hormonal therapy is for patients who tested positive for estrogen receptor tumors. For this, you use tamoxifen. It is most useful in premenopausal patients. Estrogen receptor positivity is associated with a better prognosis. Adverse effects, though, of tamoxifen include venous thrombosis, hot flashes, uterine bleeding, and endometrial cancer. Aromatase inhibitor hormonal therapy is most useful in postmenopausal ER-positive, estrogen receptor positive patients. These include letrozole, anastrozole, and exemestane. Aromatase inhibitors are more effective than tamoxifen, and they are only used in postmenopausal women since aromatase inhibition can result in a paradoxical increase in circulating estrogen in women who have functional ovaries. Adverse effects include osteoporosis, thromboembolism, myocardial infarction, hot flashes, and arthralgias. Anti-HER2 hormonal therapy. This medication is trastuzumab with or without pertuzumab, and it's added to chemotherapy regimen for tumors that are HER2 positive. HER2 positivity is associated with more aggressive tumors. Adverse effects include cardiotoxicity. However, it is reversible, and it's dilated cardiomyopathy specifically. Adjuvant chemotherapy is used to treat any residual disease. Indications include lesions that are over 1 centimeter, lesions that are associated with positive axillary lymphadenopathy, breast cancer stage 2 through 4, and inoperable disease. Options include doxorubicin, cyclophosphamide, fluorouracil, and docetaxel. Triple negative, so estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. This type of breast cancer has the worst prognosis. Okay, so now that we've gone through all of that, let's talk about breast cancer screening. Mammogram is the best screening in women who are over the age of 40. It detects breast cancer as early as 2 years before a mass can be palpated clinically. Breast self-examination has not been shown to reduce long-term overall mortality. This may also be partly due to errors in the way patients are doing it, due to poor education or not laying down while they're doing it. Most guideline bodies recommend annual screening for women aged 50 to 70, but of average risk women, the USPSTF guidelines recommend mammogram every 2 years, beginning at age 50 until 74. Women over the age of 74 can be offered screening if their life expectancy is at least 10 years. For women of moderate risk, so most patients with a first-degree relative, or in some other patients, such as they have multiple relatives with breast cancer, you could start the screening at age 50 and every 2 years like usual, or you could start 10 years prior to the age of the first degree relative that was diagnosed. You want to use that whenever was earlier. So if a patient's mom, for example, was diagnosed at age 45, then you would want to consider screening at age 35. Women with breast implants should also undergo the same screening schedule as women without them. Also, consider here patients with the BRCA gene mutation. So they want to get earlier breast cancer screening, and they want to get it every 6 months. So every 6 months, they will get an MRI or they will get a mammogram. So it'll kind of alternate. They get screened twice a year, every 6 months. So mammogram, MRI, mammogram, MRI. And then on MRI, I have a photo here all the way to the left of what a neoplasm might look like. Okay, breast cancer prevention. SERM medications can be used. That stands for selective estrogen receptor modulators. Tamoxifen and raloxifene are two of those medications. They're used in high-risk individuals. They can be used in postmenopausal or women over the age of 35 with very high risk. Treatment is usually used for 5 years. Tamoxifen is preferred because it's more effective than raloxifene, but it is associated with endometrial cancer, as I stated before. It's also more associated with the risk of DVT. When considering using a SERM, raloxifene may be preferred if patients are concerned about uterine cancer and thromboembolic risks over their risk of breast cancer. Aromatase inhibitors such as anastrozole and exemestane, these can be used in older women over the age of 60, especially those with an intact uterus. For these, AIs, meaning aromatase inhibitors, may be more appealing compared to SERMs because they're slightly superior. While on an aromatase inhibitor, bone mineral density should be monitored. Okay, now moving on to ovarian neoplasms. 90% of ovarian neoplasms are benign in women of reproductive age. The risk of malignancy increases with age. So we're starting with benign ovarian neoplasms. Dermoid ovarian cysts are also called mature cystic teratomas. These are the most common benign ovarian neoplasm. They may contain tissue derived from all 3 germ cell layers. It has a very small malignant potential. Surface epithelial tumors, stromal tumors, and germ cell tumors are the total most common types of benign ovarian neoplasms, but endometriomas are also seen in endometriosis, and these are also considered a benign ovarian neoplasm when on the ovary. Serous or mucinous cyst adenomas are thin-walled, uni or multilocular, and range in size from 5 to 20 centimeters. They are less common, but are more likely to be larger and not bilateral. Manifestations are often asymptomatic and can be an incidental finding on imaging. They are linked to ovarian torsion, though. They can rupture or become infected. Teratomas also, like I said, can undergo malignant transformation. Exam is often normal, but there may be adnexal fullness. Diagnosis: pelvic ultrasound is the initial imaging of choice with an adnexal mass. A cystic structure that may contain calcifications and hyperechoic nodules may be seen. For mature cystic teratomas, meaning dermoid ovarian cysts, a unilocular cystic mass that may or may not contain hyperechoic contents, hyperechoic lines or dots, fluid, and acoustic shadowing may be seen. Management includes surgical removal. Laparoscopic cystectomy is preferred due to potential risk of torsion or malignant transformation. Salpingo oophorectomy is another option. Ovarian cancer is the 5th most common cancer in American women and the 2nd most common gynecologic cancer, with the highest mortality of all gynecologic cancers. Epithelial cell cancer is the most common type, especially in postmenopausal women. This makes up 90% of cases. Risk factors include increased number of ovulatory cycles. So again, similar to breast cancer, this includes nulliparity, infertility, over the age of 50, early menarche, late menopause. Family history is also a risk factor, and Caucasian is also a risk factor. Genetic factors include the BRCA1 or 2 genes. Turner syndrome and Lynch syndrome are also risk factors. There is decreased risk with combination oral contraceptives with estrogen and progesterone because it may decrease the number of ovulatory cycles. Clinical manifestations: they are rarely symptomatic until late in the disease course where there is extensive metastasis. Patients may present with pelvic pressure or pain. GI symptoms include abdominal fullness, bloating or distension, increasing abdominal girth and weight loss, back or abdominal pain, early satiety, constipation, or bowel obstruction from intestinal compression. Urinary urgency or frequency is sometimes seen. Irregular menses, menorrhagia, and postmenopausal bleeding are also findings that a patient might have. Physical exam may show a palpable abdominal or ovarian mass that is solid, fixed with irregular borders. The patient may also have ascites, a pleural effusion, or Sister Mary Joseph's nodes, which indicates metastasis to the umbilical lymph nodes. Diagnosis is with pelvic ultrasound. That's the initial test of choice, which might show a over 10 centimeter mass with irregularity, and ascites are suggestive. Additional workup includes staging imaging, which might be a CT of the abdomen and pelvis, baseline CA 125 levels, which that is the tumor marker, mammogram, chest radiograph, pap smear, and colonoscopy, all to screen for other locations for metastasis. Management, stage 1, includes surgical removal, a total abdominal hysterectomy, and bilateral salpingo-oophorectomy, and selective lymphadenectomy and omentectomy. The omentum is the fatty layer over the abdomen, and it contains lymph nodes that this type of cancer commonly metastasizes to. Stage 2 through 4, surgical removal followed by platinum-based chemotherapy. So this includes cisplatin or carboplatin and paclitaxel. Serum CA-125 levels may be used to monitor treatment progress. The prognosis is very poor because ovarian cancers present so late commonly, and it's usually metastatic when it presents. Endometrial cancers next. So first we're just going to go over postmenopausal bleeding. It is usually benign. However, 10% is due to endometrial cancer. So when a postmenopausal woman presents with bleeding and they are not on hormone replacement therapy, they should definitely raise suspicion for endometrial carcinoma, hyperplasia, or a leiomyosarcoma. Diagnosis is with transvaginal ultrasound initially. If the endometrial stripe is below 4 millimeters, repeat an ultrasound in 4 months. If continued bleeding, biopsy should be performed. An endometrial biopsy should also be performed if the endometrial stripe is over 4 millimeters. Hysteroscopy may be warranted if focal thickening of the endometrium. Endometrial hyperplasia is what we'll talk about next. So this is endometrial gland proliferation with cytologic atypia. This is a precursor to endometrial carcinoma. It's most common in postmenopausal or increasing age in premenopausal women. Prolonged unopposed estrogen exposure is a risk factor here. Again, this includes chronic anovulation, estrogen-only therapy, PCOS, obesity, perimenopause, early menarche, late menopause, Lynch syndrome, and tamoxifen use. Hyperplasia occurs within 3 years of estrogen-only therapy. Increasing age is the most common cause in perimenopausal or early postmenopausal women. Clinical manifestations include abnormal uterine bleeding in quantity, timing, or the age of the patient. It's also might be associated with vaginal discharge. It could also be asymptomatic and detected on routine imaging. Transvaginal ultrasound is used as a screening test, again, when the endometrial stripe is over 4 millimeters. Endometrial biopsy is the definitive diagnostic method and is indicated if the patient is over 35, has an increase in endometrial stripe on transvaginal ultrasound, or for patients on unopposed estrogen therapy, tamoxifen, or if persistent bleeding with a thick endometrial stripe. Management, so if it's hyperplasia without atypia, management includes progestin either orally or with an IUD. The endometrial biopsy is then repeated in 3 to 6 months. For hyperplasia with atypia, a total abdominal hysterectomy is indicated. Progestin treatment is used if the patient is not a surgical candidate or if they wish to preserve fertility. Now, endometrial cancer. This is the most common gynecologic malignancy in the United States. It's 2 times more common than cervical cancer, which we'll talk about next. Endocarcinoma is the most common type. This is over 80%. It mainly affects postmenopausal women. That's 75% of cases, with a 50 to 60-year peak. Risk factors include increased estrogen exposure, again, increased ovulatory cycles, chronic anovulation, PCOS, obesity, diabetes, Lynch syndrome, and tamoxifen use. There's decreased risk with combination oral contraceptives, and these are protective against ovarian and endometrial cancers. because the progesterone component prevents unopposed estrogen. Clinical manifestations include abnormal uterine bleeding again. Mostly postmenopausal bleeding is the key one, but pre or perimenopausal bleeding that is also abnormal in quantity or timing, that may also be a suggestive feature. Diagnosis: transvaginal ultrasound will show a thickened endometrial stripe over 4 millimeters. A pap smear should also be performed. Endometrial biopsy is the definitive diagnosis. Endocervical curettage is sometimes used as an alternative. Management stage 1 is a total abdominal hysterectomy with a bilateral salpingo-oophorectomy. They might also need post-operative radiation therapy. Stage 2 and 3 might include the same total abdominal hysterectomy with bilateral salpingo-oophorectomy with lymph node excision, with or without post-op radiation therapy. Stage 4 or advanced includes systemic chemotherapy. For recurrence, you could treat with high-dose progestins or antiestrogens. Cervical dysplasia is our next topic. We're going to start with HPV vaccination. So, HPV type 16 and 18 cause 70% of all cervical cancers worldwide and 90% of anal cancers. HPV type 6 and 11 cause 90% of genital warts. Gardasil 9 targets the same as Gardasil 6, 11, 16, and 18, as well as HPV types 31, 33, 45, 52, and 58. Vaccination with the recombinant 9-valent HPV vaccine, aka Gardasil 9, can prevent cervical cancer by targeting HPV types that pose the greatest risk, as well as prevent or protect against low-grade and precancerous lesions caused by other HPV types. Indications for all women and men: routine vaccination is recommended at 11 to 12 years and can be administered starting at age 9. Dosing: individuals initiating the vaccine at 9 to 15 years of age get 2 doses given at 0 and then at 6 to 12 months. Individuals initiating the vaccine series at 15 years of age or older get 3 doses of the HPV vaccine given at 0, 1 or 2, and then at 6 months. HPV vaccine is contraindicated in pregnancy or women who are lactating. Cervical cancer screening. Screening guidelines recommend a regular Pap testing for all women who have reached the age of 21, and it is taken at 3-year intervals. Beginning at age 30, guidelines also include HPV testing with or without a Pap smear. The screening interval for women who test normal using this approach may be lengthened to 5 years. So, let's go over the timing of Pap smears based on the results. So, let's say a patient between the age of 21 and 24 tests normal for a Pap. That means their next Pap smear is due every 3 years. This is the same for patients up to 29 years old. So 21 to 29, Pap every 3 years if their result is normal. For patients over the age of 30 and they're HPV negative and their Pap is normal, their HPV and Pap co-test can be every 5 years or every 3 years, but that is less preferred. If over the age of 30 and HPV positive, then and they have the normal Pap, co-testing in 1 year, or they could do HPV genotype testing. So now, for patients 21 to 24 that test positive for ascus, so their Pap is abnormal, but the test shows, all right, there we go, atypical squamous cells of undetermined significance. Their Pap test is due in 1 year. For the same results in a 25 to 29-year-old, reflex HPV testing is preferred. For patients over 30 and HPV negative, but they test positive for ascus, repeat co-testing in 3 years. And then if over 30, HPV positive, and testing with ascus, then a colposcopy is indicated. Now, for low-grade squamous intraepithelial lesions, or LSIL, for this result in 21 to 24-year-olds, repeat the PAP in 1 year. For 25 to 29-year-olds, perform a colposcopy. If over 30 and HPV negative, then you could either repeat the PAP in 1 year or do a colposcopy. And then in over 30 and HPV positive, perform colposcopy. For the result of ASK-H, so atypical cells that can't exclude high-grade squamous cell intraepithelial lesion, so ASK-H, a colposcopy is indicated in all age groups. And then for patients who do test positive for high-grade squamous cell intraepithelial lesions, colposcopy is indicated in all age groups, or for patients who are 25 to any age over 30, regardless of HPV status, excisional treatment can be chosen. Excisional treatment options include a loop electrosurgical excision procedure, or LEEP, a cold knife conization, or laser conization. Okay, so pap smear results. We just went over the screening and then when to repeat it, but let's go over what those results really mean. So starting with LSIL, or low-grade squamous intraepithelial lesions. So the biopsy results, CIN means cervical intraepithelial neoplasia. So LSIL is CIN1. This indicates mild dysplasia contained to basal 1/3 of the epithelium. Cellular changes are seen with HPV, often transiently in young women. For women with CIN1 plus ascus, LSIL, or a normal cytology in the presence of HPV 16 or 18, it is recommended to follow up with co-testing with cytology and an HPV test at 1 year. For HSIL, or the high-grade version of this, CIN2 indicates moderate dysplasia, including 2/3 thickness of the basal epithelium. It is due to persistent HPV. Excision or ablation is the mainstay of treatment here. CIN3 indicates severe dysplasia, including over 2/3 or full thickness of the basal epithelium. Full thickness indicates carcinoma in situ, meaning it hasn't invaded the basement membrane. This is premalignant. For HSIL lesions, then again, it is ablation for the mainstay. Excision can also be used using LEEP, or ablation with cryocautery, laser cautery, or electrocautery. Okay, cervical cancer is the third most common gynecologic cancer. The first, again, to review, the first is endometrial, the second is ovarian. It is the most common to metastasize to local areas, including the vagina, parametrium, and pelvic lymph nodes. The major types are squamous cell carcinoma, that is the most common, making up 90% of cases, but adenocarcinoma makes up 10%. The spread, in order, the primary node groups involved in the spread of cervical cancer include the paracervical nodes. This is the most common and the one to remember for the exam. It takes, on average, 2 to 10 years for carcinoma to penetrate the basement membrane and become invasive, which is why Pap tests are so important. Risk factors include HPV. It's associated with 99.7% of cases, especially HPV 16 and 18, which is associated with 70% of cases. But other causative HPV strains are 31 and 33, also prevalently, but also 45, 52, and 58. But really remember 16 and 18 being the most causative, and then 31 and 33 coming in just behind that. Risk factors also include early onset of sexual activity, increased number of partners, smoking, and this is a cofactor specifically for squamous cell carcinoma. You can keep this in mind if you also remember that squamous cell carcinoma is associated with smoking for like esophageal cancer. I don't know, that helps me remember it. The most common range for diagnosis is 40 to 50. Clinical manifestations, it's usually asymptomatic in early stages. The most common symptom is postcoital or post-intercourse bleeding or spotting. Irregular or heavy vaginal bleeding with a watery vaginal discharge might also be seen. Advanced disease may present with pelvic or back pain. Physical exam may show cervical discharge or ulceration if already invasive. Diagnosis: gross lesions, or gross meaning surface level or visible with the naked eye, should be evaluated by colposcopy with biopsy, and those biopsies should be directed and not just with cytology. Cervical biopsy and endocervical curettage or conization is performed after a positive pap smear to determine the extent and depth of the invasion of the cancer. Staging of invasive cervical cancer is achieved by clinical evaluation and with further imaging, such as ultrasound, CT, MRI, lymph angiography, laparoscopy, and fine needle aspiration. These are also useful for treatment planning because the staging indicates treatment. So for carcinoma in situ, this is stage 0. Excision is preferred using loop electrical excision procedure or LEEP, or cold knife conization or ablation using cryotherapy or laser. The definitive management, if childbearing is not a consideration for the patient, should include total abdominal hysterectomy with the bilateral salpingo-oophorectomy. For microinvasive, this is stage 1A1. So this is getting a little bit in the weeds. You probably don't need to remember this as much as for carcinoma in situ. Remember excision or ablation. But for microinvasive, total hysterectomy and conization. For locally advanced disease, radiation and chemo. And for advanced and metastatic disease, you could go for systemic chemo. So lastly, vaginal cancer and then vulvar cancer. Vaginal cancer is rare. It's 1% of gynecological malignancies, and the peak incidence is between 60 and 65. Primary tumors are very rare, but the most common is squamous cell carcinoma. But more commonly, vaginal cancer is a secondary tumor from cervical, vulvar, or a distant source of cancer. Risk factors are the same as cervical neoplasia. So HPV type 16 and 18 cause 70% of cervical cancers, as we said, 90% of anal cancers, and same for vulvar and vaginal cancers. Clinical manifestations: abnormal vaginal bleeding is the most common symptom, so postcoital, intermenstrual, or postmenopausal. May also present with watery vaginal discharge or painful intercourse. For diagnosis, on visualization, the lesion may appear as a mass, plaque, or ulcer. The posterior wall of the upper 1/3 of the vagina is the most common site. For an exam, really remember this part: the posterior wall of the upper 1/3 of the vagina. Biopsy is the definitive diagnostic method, but if the lesion is not seen, a colposcopy should be performed to determine the biopsy site. Management: stage 1 includes surgical excision or radiation therapy for primary vaginal cancer. For stages 2 to 4, use chemoradiation. Radiation alone is an alternative. So now, cancer of the vulva. The most common type, 90%, is squamous cell carcinoma. Paget disease is vulvar intraepithelial neoplasia that presents as a superficial lesion of the epithelium that has not invaded the basement membrane, meaning it's precancerous. It may progress to carcinoma in situ or squamous cell carcinoma. Risk factors, again, HPV type 16 and 18, Clinical manifestations: vulvar pruritus or itching, bleeding or pain. The labia majora is the most common site, 50%, followed by the labia minora, and rarely the clitoris or Bartholin glands. Examination will show a red or white ulcerative or raised crusted lesion. Diagnosis is with biopsy. Acetic acid or toluidine blue application may help aid the biopsy. Management is with excision, radiation, and chemotherapy with 5-fluorouracil. Okay, finally, we have made it through the neoplastic disorders, and we have just 3 topics left. So first is contraceptive methods. We will start with emergency or postcoital contraception. So in order from the most efficacious to the least efficacious, the most effective is the copper IUD, then the levonorgestrel IUD, and then oral levonorgestrel is last. When used for emergency contraceptive, the copper and levonorgestrel IUDs result in pregnancy rates below 1%, so they're very effective. Copper IUD is the most effective method of emergency contraceptive if inserted within 5 to 7 days after unprotected intercourse. This prevents up to 99% of pregnancies. Levonorgestrel is ideally given within 72 hours after intercourse, but is effective up to 5 days after intercourse. The mechanism: it inhibits or delays ovulation. It reduces the chance of pregnancy by 75 to 99%, dependent on the modality of administration, IUD versus oral. High-dose estrogen progestin is ideally given within 72 hours of unprotected intercourse. The mechanism: it may inhibit or delay ovulation. Common adverse effects are nausea and vomiting. And then ulipristal, or UPA, is a progestin receptor modulator that delays ovulation. Must be taken within 5 days after intercourse, and it's the most effective oral emergency contraceptive, but it does require prescription and is not stocked in all pharmacies. Now moving on to estrogen and progesterone oral contraceptives, or combined oral contraceptives. These prevent ovulation and implantation by inhibiting the mid-cycle LH surge. It thickens cervical mucosa, and it thins the endometrium. Failure rate is 9% on average. However, this is mostly used to inconsistent taking of the medication or other issues with the taking of the medication, because when it's used correctly, the failure rate is 0.3%. Often start with the onset of menses or within 5 days after the start of menses. Advantages: so it may improve dysmenorrhea, abnormal uterine bleeding, acne, and hirsutism. It protects against osteoporosis, ovarian and endometrial cancers, and it reduces ectopic pregnancy risk. Disadvantages is it increases hypercoagulability, which is why if during the exam you see a patient with a DVT or a PE, consider oral contraceptives as a causative mechanism, or at least contributing mechanism. There's also a slightly increased risk of hepatic adenoma. It may also cause increased fluid retention, increased triglycerides, cholestasis, and diabetes mellitus risk. Contraindications include a risk of ischemic heart disease, a DVT, PE, or stroke, breast cancer, or migraines with aura. Smokers should stop the use of oral contraceptives if over the age of 35. Severe hypertension, meaning systolic over 160 or diastolic over 100, is also a contraindication. So, progesterone-only pills are also called the mini pill. It uses norethindrone. The mechanism: it thickens cervical mucus, thins the endometrium, and suppresses ovulation. These are used in women in whom estrogen-containing contraceptives is either contraindicated or it causes additional health issues. It's often initiated on the first day of menses. The pills must be taken at the same time each day to maximize efficacy. Advantages, so it has no estrogen-related adverse effects, and it's safe during lactation. It also reduces the risk of endometrial cancer. However, it can cause unscheduled bleeding and changes in menses. So progesterone-only contraceptives, injectable options, so these are other than oral. Injectable, so this is the depot shot or depomedroxyprogesterone. It lasts 3 months. It has a 5% failure rate. It suppresses the pituitary FSH and LH secretion, and adverse effects include menstrual changes, calcium loss, bone weakness, and osteoporosis. So it's not usually used for more than 2 years. Progestin implants, so think of the Nexplanon. They have a 0.05% average failure rate, and it lasts 3 years. Adverse effects include headache and menstrual irregularities. The copper IUD, before the copper IUD, the intrauterine levonorgestrel is good for 5 years. It induces inflammation, causing a hostile environment to a fertilized ovum. It's usually inserted during menses to ensure the patient is not pregnant. Uterine perforation is an adverse effect or potential one. Increased risk of ectopic pregnancy and PID. There may be cramping or bleeding with menses, and risk of spontaneous abortion if pregnancy does happen to occur, although the risk is very low. So now, copper IUD. It causes inflammation that makes a hostile environment for the sperm and ova. It has a 0.5% failure rate. The advantages include a 10-year duration of action. It's a very effective contraceptive method. There's no exogenous hormones. It does not cause anovulation or amenorrhea, and it can be used for emergency contraceptive and left in place for ongoing contraception. Adverse effects include incidence of PID and heavier periods, the latter being more common. Clomiphene citrate. So this is a partial estrogen receptor agonist that stimulates ovulation via the hypothalamus, which leads to increased LH and FSH release. Indications: it induces ovulation to enhance fertility, especially in patients with polycystic ovarian syndrome. So I guess you could say this is the opposite of birth control, right? But it also helps with infertility due to anovulation. Adverse effects: hot flashes are the most common. Ovarian enlargement, multiple gestation pregnancy, abdominal discomfort, and visual changes may also be adverse effects. Leuprolide, so this is a gonadotropin-releasing hormone analog. Indications: it is given pulsatile in a way to enhance fertility, and it could also be used to inhibit estrogen and progesterone. This is when it's given continuously for women with uterine fibroids or men with advanced prostate cancer. Adverse effects of continuous dosing include hot flashes, depression, and osteopenia. Danazol is a hypoestrogenic and hyperadrenergic medication. It's given in endometriosis, fibrocystic breast disease, or hereditary angioedemas. It has limited use due to the hyperandrogenic adverse effects, which include weight gain, acne, hirsutism, and virilization. Okay, now going into non-medical. So male condoms, these are often made of latex and it covers the penis. It's the only method that effectively protects against pregnancy and STDs, including HIV. However, disadvantages include possible allergies. A diaphragm with spermicide. This is a barrier inserted over the cervix that prevents entry of sperm. It has some protection against STDs, but it must be fitted by the provider. Female condoms are barrier sheets inserted into the vagina. It has some protection against STDs, but it can be difficult to use. And then natural family planning or fertility awareness methods. These is this is used when sexual intercourse is avoided on the days in which the menstrual cycle or when conception is likely, so like near the time of ovulation. There's really no side effects, but it requires the partner's participation. There's no STD or HIV protection. And the least effective methods include withdrawal, which is when the penis is removed before ejaculation. There's no side effects, but there's no STD or HIV protection. It is not recommended as a first-line method. The same goes for spermicide. This is a substance that inhibits sperm motility. It can be used as a second degree method, but not a first degree, and that's when above I mentioned a diaphragm with spermicide. Okay, now talking about sexual assault, we're just going to talk about the workup and then treatment. So first, when a patient comes in reporting sexual assault, conduct a complete physical exam, make notes of any signs of trauma, do a detailed pelvic exam, including the survey of the external genitals, the vagina, cervix, and anus. So for really diagnosis here, this is for potential, I suppose the word would be consequences of sexual assault. So do a smear/culture for gonorrhea and chlamydia, including a rectal smear culture if appropriate. You can do a wet mount and culture for trick. On an individual basis, consider serologic testing for HIV, syphilis, HSV, HBV, and CMV. Also perform a serum pregnancy test. A blood alcohol level and urine tox screen can be considered in specific cases. Treatment. Treat the patient's traumatic injuries, STD treatment and prophylaxis. So prophylaxis for STDs might include ceftriaxone with azithromycin with or without metronidazole. HPV vaccination can be helpful if a patient has not received the full series. HIV risk assessment and possible post-exposure prophylaxis can be prescribed. Emergency contraceptive for pregnancy prevention if needed. Refer for psychological counseling. Arrange for follow-up with the same physician or with another provider if more appropriate. And then follow-up should include repeat screening for STDs, repeat screening for pregnancy, and discussion of coping methods with appropriate referrals for psychiatric care if needed. Also keep in mind here that first, because this will often happen in an ER, but it can also happen in primary care. So in the ER, there's commonly like specialized providers that are trained specifically in how to handle sexual assault cases, because a lot of times you'll also have to call a forensics team that might document or take histories, and this would aid in a potential police report in the future. Also, the reason for using like a blood alcohol level or urine tox screen, this can help in a future police investigation to indicate a lack of consent given the like ingestion of any substances. And basically, yeah, like specialized care is needed here, and with like nurses who are specially trained, that could be very helpful. And making sure that the patient isn't or is less likely to be lost to follow up, making sure they get the care they need even after that first visit. Next, spouse or partner neglect/violence. So, intimate partner abuse. 1 in 4 women and 1 in 7 men will experience physical violence by their intimate partner at some point during their lifetime. About 1 in 3 women and 1 in 6 men experience some form of sexual violence during their lifetimes. A woman who leaves an abusive partner has a 70% greater risk of being killed by that abuser compared to when they're staying. This makes it the most dangerous the most dangerous time to be a victim of intimate partner abuse. Abuse during pregnancy can make up about 10% of pregnancy-related hospital admissions. Barriers to screening include a lack of privacy, or if the partner's there, a low self-esteem from the patient, fear, and the sensitive nature of intimate partner violence. But Clues to violence include contusions, meaning bruises, to the breast, chest, abdomen, face, neck, musculoskeletal injuries, and quote-unquote accidental injuries. They may have multiple injuries and various stages of healing. Patients may have nonspecific general symptoms such as fatigue or headache. Management. All healthcare facilities should have a plan that includes screening, assessing, and referring patients for intimate partner violence. Once suspected, patients should be addressed directly with a non-threatening question to confirm if intimate partner abuse has occurred. If it has occurred, then alternatives should be discussed with referral if the patient accepts it, as the patient's right to accept or refuse help. Sexual abuse. More than 1/4 to 1/3 of female children have experienced sexual abuse before the age of 18. The most common ages of sexual abuse are between ages 9 to 12. Most abusers are relatives or known to the child, and increased suspicion along with the risks or hints to intimate partner abuse include, and this is specifically for children, that exhibit sexual knowledge, if they initiate sex acts with peers, if they show knowledge of sexual acts, bruises, pain, or itchiness in the genital or anal area, or evidence of STIs in children of this age. So that was a little bit heavy to end off with, so I figured that we should go into 5 practice questions just to assess knowledge from this video or the past 2 videos. So, question 1. What are the main differences in the histories and physical exams for patients with endometriosis versus adenomyosis? You can pause here if you want a moment to think about this, but otherwise, I will give the answers right now. So, both of them will present with dysmenorrhea, pelvic pain, and abnormal uterine bleeding. But in endometriosis, 1/3 of patients are asymptomatic. They might present with specifically premenstrual pelvic pain, pain during intercourse, or with defecation. The exam is normally normal, and it may or may not have painful nodules and restricted range of motion. Adenomyosis, on the other hand, is most often asymptomatic, but it may present with progressively worsening menorrhagia, symmetrically enlarged soft mobile uterus, with or without tenderness. Question 2. A 16-year-old female with primary amenorrhea, she is Tanner stage 1 for breast development and stage 2 for pubic hair growth. What lab tests are indicated as the next best steps in the workup of this patient? Again, you could pause, but I will give the answer in 3, 2, 1. FSH and LH are the 2 ones I was going for, but other initial tests include a beta HCG pregnancy test, a TSH, and prolactin. Question 3. A woman comes in with complaints of nausea, rash, hair loss, and headaches. She says she just finished her course of medication for vaginitis, but she forgets her exact diagnosis and the medication she was taking. Lab results reveal elevated liver enzymes. What is the most likely causative agent, meaning the medication? All right, you can pause, but I will give the answer in 3, 2, and 1. Fluconazole. Remember, fluconazole causes hepatitis. Question 4. What is the most common type of breast cancer, and what are some of its characteristics? You can pause, but I will give the answer in 3, 2, and 1. Infiltrative ductal carcinoma is the most common type of breast cancer, and it's associated with metastasis to the axillary lymph nodes and is characterized by cords and nests of cells with variable gland formations. Okay, cool. I accidentally included the answer in this one, but if you're not looking at the screen, a patient is diagnosed with gonococcal cervicitis. Her chlamydia status is unknown, and she weighs 73 kilograms. What is the treatment of her condition? If you are not looking at the answer on the screen right now, it is a single dose of ceftriaxone, 500 milligrams IM, and a 7-day course of doxycycline, 100 milligrams BID. So thank you for listening. These are the resources I used. I got all of these, all of the information here from Lecturio, Osmosis, Radiopedia, Medizi, Pance Prep Pearls, and SmartyPANCE. And then next, you could look out for my video on obstetrics that is coming soon. Thank you for listening, and I hope this was helpful.